I'm so happy to be able to have the opportunity to speak to everyone today about a disease process that I see very frequently, and I care for a lot of patients who suffer from this condition. So my name is Dr. Mallory Stuparich. I'm an assistant clinical professor in the Department of OBGYN at the University of California, Riverside School of Medicine. I do have my social media there, so if you'd like to give me a follow, then feel free. And with that, we'll go ahead and get started. Oops, gotta be careful with my clicking. I'll go too quickly here. Let's go back. Suyan, can you go back to to the previous slide?
Yeah, of course.
Thank you. So first and foremost, I think anytime we're discussing a medical condition or a disease process, it's important to understand what it is. And so we usually start with what the medical definition of what endometriosis is. So it is medically defined as the presence of endometrial glands and stroma outside of the normal location. And the normal location is typically what lines the uterus, or the inside part of the uterus, which is where, if somebody were to be pregnant, where a baby basically lives and grows. Now, just because it looks the same way under a microscope, it doesn't necessarily mean that it behaves in the same way. And I think it's important to keep that in mind. It is diagnosed surgically, but when patients come in and they discuss their history and discuss how long they've been suffering and everything that's been going on, we can certainly have a very high suspicion.
Bismillah, are you okay?
We can certainly have a very high suspicion that that a person may have endometriosis. Okay, but it is confirmed via surgery and biopsy. If you come on, if you wouldn't mind, please muting your Zoom, I'd appreciate that. Okay. So what are the symptoms of endometriosis? So the symptoms are typically, they comprise a few different things, and not all patients have to have all these symptoms. But when I'm teaching medical students, we're typically talking about the 4 Ds. And I've put the medical terms in parentheses next to the symptoms that I'm about to explain. So endometriosis symptoms can encompass any of the following. A patient may have very painful periods, which is what we call dysmenorrhea. They may have pain during sexual intercourse, which we call dyspareunia. They may have pain when trying to urinate, or if their bladder becomes full, which we refer to as dysuria. They may have pain when attempting to have a bowel movement, which we call dyschezia. Typically, after a long period of time, when these symptoms go on and persist for a long period of time, it can actually lead to patients having pain outside of the time that's immediately surrounding their cycle. And so we term that non-cyclic pain. Another symptom that a patient may present with is they may have difficulty becoming pregnant. And Dr. Behbehani, my colleague, will discuss more about this later. If it's quite advanced, sometimes patients can have deeply infiltrating endometriosis that may be invading into their intestines, or maybe invading into the ureters, which are the tubes that connect the kidney with the bladder. And so some patients can actually have obstruction of these organs, and that typically is disease that's quite advanced. Okay, so if we were all in person, I would stop and I would have everybody stand up and say, painful periods are not normal. I wish that I could take out some billboards and have basically a national campaign Oh, Suyan, if we could go back to the previous slide. Suyan, I think I'm actually going to have you go ahead and control. There seems to be a little bit of a delay and I don't want to have it be too confusing. So I'm going to go ahead and have you control the slides.
Right, yeah, just let me know when you're ready to advance to the next slide.
Of course. Yeah, and so like as I was mentioning, I feel as though this is something that I want to just shout from the rooftops and advertise everywhere, that painful periods are really not normal. And I'll come back to this a little bit later when I'm discussing some of the patient perspectives and what we know from the evidence of surveying patients. And so Suyan, let's go ahead and go to the next slide, please. So I'm going to go ahead and we actually have a chat. And so I'm going to explain to you all how this will work. So I want us to go ahead and use the chat function. And I'm actually going to give you a countdown of saying 3, 2, 1, go. And I don't want you to enter your answer until I say 3, 2, 1, go. So we're going to do almost like a burst. I like this technique. So Suyan, next slide, please. So you all might not have known that you're going to have a quiz today, but okay. And so first and foremost, I'd like to ask what you think the prevalence of endometriosis is in women of reproductive age. And so we'll take maybe about 10 seconds. Hold your answers though. Please don't enter them quite yet. Okay, 3, 2, 1, go ahead and enter your answers. Okay, great. Wonderful. Okay, excellent. Suyan, go ahead and go to the next slide, please. Yeah, so for those of you that said B, you would be correct. Okay, next slide, please. All right, now we're going to pare that down a little bit more. So what is the prevalence of endometriosis in women who are determined to be infertile? And let's take 10 seconds. Hold your answers, please. And then I'll give you the countdown. Okay, 3, 2, 1, go. Okay, great. Okay, go ahead and go to the next slide, please. So for those of you all who said D, it is 38%. And next slide, Suyan. All right, so lastly, again, paring that group down a little bit further, what is the prevalence of endometriosis in women who have chronic pelvic pain? So again, take 10 seconds, think of your answer, don't enter it quite yet. Okay, 3, 2, 1, go. Okay. Okay, a little bit more variety in the answers. Okay, Suyan, next slide, please. Yeah, so for those of you all who said C, you would be correct. Next slide. And so I think it's very important to think about the patient perspectives. And this is a slide that I really like to bring home for the students and trainees that I teach. It is very common for patients to go years without having a diagnosis. So delays of around 4 to 11 years are quite common. And this delay is exacerbated by the fact that a lot of these symptoms are very normalized in society. Even well-meaning relatives can normalize these symptoms. You know, relatives might say things like, yeah, well, this is what I had to deal with. So unfortunately, you know, you have to deal with it too. I see a lot of patients who have a lot of coexisting diagnoses that may be almost masquerading as endometriosis. So a lot of patients come in with diagnoses related to their bowels or related to their bladder. And so that's, you know, those are several reasons why the delay might be exacerbated. Why does it matter? Well, it matters for many reasons. First and foremost, the whole time the patient is waiting for a diagnosis, the patient is suffering. So there's a significant decrease in quality of life. You can imagine a patient going through this, who maybe is not listened to by doctors or dismissed, or, is unable to find the answer that the patient needs. This would definitely put a strain on the physician-patient relationship and may lead to distrust and really not having a sense of faith in the medical community. There is a process it's beyond the scope of this particular presentation, but all the while a person is in pain, the longer that they're in pain, the harder it is to relieve that chronic pain that's been there for so long. This process is called central sensitization. So all the while this patient is suffering, this process is developing, and it can be quite the uphill battle to come back from that. And the disease may be progressing and physically growing within the patient, which can lead to more scar tissue and may result in the patient having difficulty becoming pregnant if that's something that they desire, and ongoing pelvic pain, as well as a damage to other organs. Next slide, please. So this was a survey of about 638 respondents that sought care for several different types of pain. The mean time from the patient recognizing that they have symptoms to diagnosis was 4.4 years, so quite a long time. The mean time to getting a first consultation with a physician for women in their 40s was a little over a year. For women who in their adolescence, it took much, much longer. It took a little under 4 years for them to have a consultation. And then looking at women who the time between first consultation to actually receiving a diagnosis, again, for women in their 40s was about a year. And for, again, the poor adolescents, just under 3 years. I put this in here to highlight the fact that actually one of the biggest red flags for an adolescent possibly having this disease is something called absenteeism, where they're having to call a relative or somebody to come pick them up from school because their pain is so bad. So that's definitely something I keep on my radar when I speak to parents or adolescent patients. Next slide, please. So what are the treatment options? And again, just given the time we have allotted here today, it's a little bit beyond the scope to get into a really full counseling session. And really that's something that I think is most appropriate between the patient and the physician. But basically there are three, I guess, management options that are typically proposed for patients. So expectant management. Endometriosis is not a cancer. It's not a life-threatening disease, but it's absolutely a quality of life impacting disease. And so you may hear some physicians say, well, we can just watch it and see what happens. But I would probably argue that the vast majority of patients that are coming to see an endometriosis specialist have been doing a lot of watching and waiting, and that's not going to be feasible for much longer. Medications, you can see the list there. Sometimes we're talking about over-the-counter pain medications, use of hormone therapy. For a complete discussion, I just mentioned Leuprolide and Elagolix. Medications typically are more palliative. They're treating symptoms. Unfortunately, there does not exist a pill that magically makes endometriosis go away. It hasn't been invented yet. It just doesn't currently exist. So medications really are used for symptom management. They're not directly treating disease per se. Some patients get told a hysterectomy may cure endometriosis, which if we think about what we started out at the top of the lecture saying, endometriosis by definition exists outside of the uterus. So it makes you wonder how removing the uterus might actually treat endometriosis. So I'll leave you with that thought and happy to take any questions on that. The surgery that I perform a lot, as well as my colleague, Dr. Behbehani, is what we call a laparoscopic or a minimally invasive excision of endometriosis, where we are dedicatedly going in, investigating for the disease and actually cutting and removing the disease from the body. Next slide, please. And that's what we'll focus on for the remainder of the talk. Next slide, please. Next slide. So what am I looking for? Well, the lesions could be highly variable. Classically, they're taught as looking like a powder burn or a gunpowder type of lesion. How they look can really depend upon how old the patient is. Next slide, please. And so I hope everybody's okay with surgical images, but I wanted to just show you what we see during surgery. And so actually, I don't know if I have the pointer, but you can see these dark gray to black lesions. This is actually looking underneath a patient's left ovary. You can see that at the top of the screen. The ureter is in play here. The ureter, again, is that tube that connects the kidney with the bladder. And you can see these lesions that look like little pieces of gunpowder have been fired on the skin on the inside of the body. Yes, right there. And this is a very classic appearance of endometriosis. Next slide, please. This is a little bit more extensive of a lesion in the same area as we were looking at. This is obviously a different patient. But again, you can see these blebs of black gray tissue, almost there's some scarring in this white fibrosis. And so this is not normal. This was confirmed to be endometriosis. Next slide, please. Now, this is on the right side of a patient, underneath a patient's right ovary. You can see that demarcated on the right-hand side of the screen. Again, that ureter, which is the tube that connects the kidneys with the bladder, we see down there. And this sort of red vesicular-looking lesion that's just above that ureter term. So, this is not a typical classic appearance of endometriosis. This is actually more atypical. It is typically a younger endometriosis lesion. And this could be something that may be passed over by somebody who doesn't have experience with knowing what these lesions look like and the variability of them. Next slide, please. So there's a lot of ongoing debate in endometriosis circles about excision, which is the cutting out of the lesion, versus ablation, which is almost using an electrosurgery approach to cauterize the lesion. And so that's why you see the scalpel and the fire on the right-hand side. There are many studies that support excellent outcomes in pain improvement with excision versus ablation. And the benefits that excision gives us is that, number one, it allows us to actually make a diagnosis. Interestingly, in surgeons who maybe don't perform endometriosis surgery very frequently, what they think may be endometriosis at the time of surgery, they are actually only right about 41% of the time. Now, somebody who has a lot of experience performing endometriosis surgery is right about 81% of the time. But you notice I didn't say 100%, okay? And so, even experts are not as good as visually identifying endometriosis as we may think that we are, which is why biopsy and confirming it on pathology is very important. Why? Well, incorrectly diagnosing a patient may lead to anxiety that's unnecessary, may lead to treatments that are unnecessary. So getting the diagnosis correct is very, very important. Excision allows us also to completely remove the lesion. Many times it can almost be like an iceberg where you just see the tip of the lesion. And if you just burn that, you're missing the deeply infiltrating area underneath. And you have to ask yourself, how do you know that you burned or cauterized down to normal tissue? Next slide, please. It allows us to have a cutting out or excising, allows us to have a margin around the implant, which they have found secret or hiding disease in up to 13% of the margin around the lesions that looks normal. And then lastly, the burning can actually cause carbon deposits and scar tissue that actually looks like endometriosis when somebody looks later. And so it can confuse the clinical picture and diagnosis a little bit. And then there's also the question of harming the structures that are nearby, because that energy can spread to some of the nearby organs. Next slide, please. And so the big take home point that I want you all to leave with is that painful periods are not normal. And there are specialists who care for patients who have endometriosis very frequently. And we are here and we can help you and evaluate you, and really, get that quality of life back. So next slide, please. Here's some resources if you're interested. Next slide, please. And with that, I'm going to go ahead and kick it over to my partner, Dr. Sadiqa Behbehani.
Thank you, Dr. Stuparich. Can everyone hear me? Yep. Okay.
Yes, I can hear you.
Great. Thank you. So Dr. Stuparich, that was great. Thank you for explaining how endometriosis typically grows and also for reinforcing the fact that painful periods are not normal. I am Sadiqa Behbehani. I'm a reproductive endocrinologist and fertility specialist, as well as a minimally invasive GYN surgeon, and I'm here to continue the talk on dispelling the myths related to endometriosis, and I'm specifically going to focus on fertility. Can I advance my slides on my own, Cyan? Can I try that?
Yes, you should be able to. So let's see if that works.
If I can't, I'll ask you to advance the slides for me, but I would like to try it.
Yeah, you should be able to do it now.
Okay, so far nothing's happening. Here we go. So Dr. Stuparich showed some excellent pictures of endometriotic implants behind the ovaries, on the ureters. But how about disease that grows on the ovaries? So one of the very, very common myths related to endometriosis is patients get told that they cannot get pregnant naturally if they have endometriosis. And Dr. Stuparich was able to teach us something today by asking the question of how many women who are not able to get pregnant have endometriosis. But now let's ask the reverse part of that question. So when women who are diagnosed with endometriosis, how many are unable to get pregnant? And the answer is only 30%. So 70% of women who are diagnosed with endometriosis can conceive naturally. And that's very important. I think it's skipping slides, Cyan.
Okay.
You can control the slides for me if we can go back to this slide. And so it's very important to recognize that not everybody with endometriosis will have infertility. And to have a 20, 25-year-old patient here that they're probably not going to get pregnant in the future when they're ready to have children can be very distressing. It can really affect their quality of life. It can really put a lot of pressure on the patient to try and get pregnant as soon as possible because they're being told that they have a disease that will prevent them from conceiving. And that's completely inaccurate. A lot of women get pregnant naturally with endometriosis, especially if we recognize the disease and we remove the disease. So out of women who have endometriosis, 30% may have issues getting pregnant. And typically, the more advanced the disease is, the more difficult it is to get pregnant naturally. And so why can women with endometriosis have difficulty getting pregnant? One of the biggest reasons is ovarian endometriosis. So like Dr. Stuparich said, endometriosis is when tissue that normally lives inside the uterus makes its way outside the uterus, and it can implant on the ovaries. And if we look at the pictures here, I don't know, Cyan, if you can use your mouse to point out, but that big blue cyst on the left side, this is a big endometrioma. Can you use your mouse, Cyan? Yep, exactly, right there. This is a big endometrioma, perfect. And then if you look at the other side, the white stuff, no, same picture, please. Same picture, that's the other ovary. So that's how an ovary should look. So what Cyan is pointing to now is the fallopian tube, and right underneath it, the white structure is the right ovary. So this fallopian tube and ovary look completely normal. On the other side, you see a really big inflamed ovary. Sorry, same picture, Cyan. Other side, other ovary. Yep. You see a big inflamed ovary, that blue cystic structure, and that's a large endometrioma on the left ovary. So, just by looking at it, you can see that the eggs growing on that left ovary are probably not going to be healthy because they're surrounded by so much inflammation and so much disease. And so one of the biggest concerns with endometriosis of the ovary is egg quality. because the endometriotic fluid, that blue tinge that you see to the ovary, is causing a lot of inflammation around the entire ovary. So even if you're able to get eggs out of that ovary, those eggs are probably not going to be of really good quality. Now, sometimes the cyst is not that big. So if we look at the next picture now, Cyan, on the right side, there's a tiny blue dot on that right ovary. This is a very small endometriotic implant on that right ovary. Now, who's to say that this implant is not going to turn into a big cyst in 1, 2, or even 3 years? We don't know. Some people have disease that grows very slowly, and other women have disease that's more aggressive and grows very rapidly. We treat endometriosis exactly like cancer. We know that if you find a tiny spot of cancer, it's going to grow into a big lesion one day. And so you don't leave it and say, oh, it's tiny today, it'll be fine. We remove any abnormal lesions we see inside or outside the ovary. And why do we do that? Because any lesion can cause inflammation in the pelvis that can reduce pregnancy rates. So even though this lesion looks really tiny on the ovary, that could be the entire reason why the patient has not been able to get pregnant, because that tiny lesion may be causing inflammation in the pelvis. And so it's important to excise or remove any disease we see. Like Dr. Stuparich said, some people will ablate or burn the lesion, but if you burn the lesion, then you're causing a lot of damage to the surrounding ovarian tissue. And when we're doing surgery on the ovaries, we want to be very delicate. We want to use as little energy as possible in order to avoid damaging the surrounding healthy eggs. Next slide, please. Another issue that we commonly encounter with endometriosis is the presence of adenomyosis. So what is adenomyosis? I like to call it the evil twin sister of endometriosis. So just like endometriosis is tissue that's not supposed to be there, that has grown outside the uterus, adenomyosis is tissue that has made it to the muscle lining of the uterus. So it hasn't really made it all the way outside the uterus, but instead of the lining living inside the uterus, it has traveled to the muscle layer of the uterus. And this again can cause a lot of inflammation and swelling of the uterus. And so studies are variable, but they show that in women who have endometriosis, about 30 to up to 70% may also have adenomyosis. Like Dr. Stuparich said, endometriosis is a diagnosis that we do with a pathologist. So I, as the surgeon, remove the tissue and the pathologist looks under the microscope and see those endometrial glands and stroma that are not supposed to be there. It's the same with adenomyosis. I can say I suspect it and I see features suggestive of adenomyosis, but the only way to diagnose it is to remove the entire uterus and have the pathologist look under the microscope and confirm that there's adenomyosis. But in women who are trying to get pregnant, that's not possible. We want to save the uterus because we want to carry a pregnancy. And so in those situations, we can suspect adenomyosis, and we know that adenomyosis may reduce the chances of pregnancy, but it doesn't mean that women cannot get pregnant with adenomyosis. We can still get pregnant. We can still reduce the inflammation by removing all the implants outside the uterus. And some women may be able to conceive naturally, and others may need help with assisted reproductive techniques like IVF. I showed this picture here just to show a different approach. You've seen a lot of laparoscopy pictures from the outside. This is the inside of the uterus. So the inside of the uterus sometimes has scar tissue. Picture C is showing a band of adhesion. Picture B, you see a lot of red spots. Yep, this can be suggestive of adenomyosis when you see microhemorrhage, micropolyps, some inflammation or abnormal coloring of the uterine lining. We biopsy it. So this biopsy is not going to affect fertility negatively. This biopsy allows us to get tissue from inside the uterus, and the pathologist can look at the tissue and comment on whether or not they see those glands and stroma inside the lining of the uterus or in the muscle layer of the uterus. Next slide, please. Okay, so remember we said that women with endometriosis may have difficulty getting pregnant. So how can we help them? This was a very interesting study that was done on women who had issues getting pregnant, tried IVF twice, were not able to get pregnant, and then had surgery to remove endometriosis. Okay, so let's look at our group again. They're women who have endometriosis, who tried 2 IVF cycles, were not able to get pregnant, had surgery to remove the endometriosis, then tried to get pregnant again. And interestingly, in this infertile group, up to 50%, so 43.8%, almost 50% were able to get pregnant after surgery. And in those patients, about 22% conceived naturally, so they didn't even need IVF, and a third required IVF. This is very interesting data because this is telling us nothing has changed with this patient except the surgery to remove the endometriosis. And once the endometriosis was removed, about a quarter of those patients were able to get pregnant naturally. That is excellent news, and they failed IVF already. And so in women who have endometriosis, who are trying to get pregnant, it's always a really good idea to see an endometriosis surgeon who can talk about surgery, because surgery may be all that's required to get rid of the disease to help not only improve pain, like Dr. Stuparich discussed, but also improve fertility, because that inflammation in the pelvis is not good for anything. It's only going to get worse with time. It's going to cause the tubes to stick together. It's going to cause the embryo. So even if we have a good embryo, it's going to cause issues with implantation. So that embryo is not going to stick to the lining of the uterus if there's a lot of surrounding inflammation. And so this is one of my favorite studies to quote because it proves what endometriosis surgeons have been saying all along, that endometriosis needs to be removed before IVF. So IVF doesn't fix everything. If you have endometriosis and you try to go through IVF, it may not work if there's still inflammation in the pelvis. Next slide, please. This is another study to show the same findings. And this is one of my favorite studies because I was involved in it. So we looked at all the evidence available in the literature to support women who have IVF or who are trying to get pregnant and then have surgery and then try and get pregnant after surgery to see if there's any improvement in pregnancy rate. So a meta-analysis basically means pooling all the data from different studies done across the world to see what their cumulative results show. And again, very similar to that last study that I just quoted, people are all infertile, they're all having issues getting pregnant, they have surgery, you remove all the endometriosis, and 44% of those patients get pregnant. And out of those patients, 30% get pregnant naturally, and 21% get pregnant with IVF. So again, that's important information telling us that endometriosis in itself may be the only cause of infertility, and removing that endometriosis may reverse the problem and may help improve chances of natural pregnancy, not only pregnancy with IVF. And for those of you who've gone through IVF, we know how stressful it can be on the couple. It's expensive, it's time consuming, it's a lot of injections, a lot of hope. And if we can avoid that and have women get pregnant naturally, that just means more pregnancies in the future without having to go through all the stress of IVF. And not only that, I always tell my patients, we have 2 issues going on. We have pain and fertility. If I fix one problem and get you pregnant with IVF, you're going to give birth to this baby and still suffer through painful periods. And we don't want that for you. We want you to feel better about yourself before you're ready to take care of someone else. And if you're in a lot of pain all the time, then you're not going to be the best version of yourself for that baby. And so going through surgery helps improve the quality of life and helps us achieve our goals of getting a woman pregnant and getting the pain under control. Next slide, please. This is a study that I accidentally stumbled upon when I was looking for something else, and it really caught my eye because the title is, Could Surgeons' Expertise Resolve the Debate About Surgery Effectiveness in Treatment of Endometriosis-Related Infertility? So what this group of observers did is they compared pregnancy rates after laparoscopic surgery with an expert and a normal laparoscopic surgeon that's not experienced in endometriosis or infertility. And they noticed that women who had surgery with a fertility specialist who specifically trained in endometriosis were able to achieve higher pregnancy rates than women who had surgery with a laparoscopic surgeon who feels comfortable operating around the pelvis. And so it's important to recognize that reproductive endocrinologists have, reproductive organs outcomes really focused on, so that when they're operating, their goal is to preserve as much of the ovarian tissue as possible. Their goal is to normalize the fallopian tubes whenever possible. And so having surgery with an experienced reproductive endocrinologist who's trained in endometriosis may yield better outcomes compared to a minimally invasive surgeon or a gynecologic surgeon who may not have as much experience with endometriosis and infertility. Next slide, please. And so we wanted to leave time at the end for Q&A. This is our information. This is Dr. Stuparich and this is myself. And we both work at UCR Women's Health. This is our contact information. If anyone's interested in seeing us for anything GYN related, endometriosis specifically, because that's what we're here for today. But Dr. Stuparich also does everything else minimally invasively, hysterectomies, fibroids, and so do I. And I also do infertility treatment, IVF, IUIs, and anything related to endometriosis and surgery. Before we open this up to questions, I wanted to add one more thing. I think I skipped over a slide at the beginning. We talked about fertility related to adenomyosis. We talked about fertility related to the ovary, but I skipped the fallopian tube slide. So another important organ that helps get the egg and the sperm together is the fallopian tube. And so a lot of the times the fallopian tubes get damaged and scarred with endometriosis. Sometimes at the end, it's the endometrioma in the ovary that invades the tube. And other times it's just scarring and endometriosis around the fallopian tubes. And so part of our goals with surgery is to help restore the anatomy and help restore the anatomy of the fallopian tube to get it functional so that women can get pregnant naturally. But that's not always possible. And if we go in and the tubes are completely distorted, sometimes they're dilated with fluid. We call that a hydrosalpinx. And a hydrosalpinx usually cannot be fixed surgically. If there's fluid in the fallopian tube, that fluid can go backwards through the endometrial cavity and wash out an embryo that's trying to stick. And so that fallopian tube needs to be removed at the time of surgery. And so that's also another important consideration why you may need an REI present at the time of surgery is this tube salvageable? Can I fix that tube? Or do I need to remove that tube because keeping that fallopian tube can negatively impact the chances of pregnancy after surgery? And that's a discussion that I typically will have with my patients prior to surgery so that I can be the best advocate for them during surgery. But I also want to observe their wishes and I want to respect their wishes for whether or not they are comfortable having that fallopian tube removed, if in my expert opinion, I think it needs to be removed. That's it. So just wanted to bring that up since we kind of skipped over it at the beginning. Now we'll open it up to questions. Dr. Stuparich is here and you can type questions in the chat box or you can unmute your mic and ask us questions. We have about 10 to 15 minutes for questions. So go ahead, everyone. I see a question in the chat box. Cyan, do you want to navigate the chat box or do you want me to read them out?
I can do that for you if you would like me to, or you can
and
also
Dr.
do that.
Stuparich will take turns answering questions, unless
Sure.
someone has a specific fertility related question for me or is question related to Dr. Stuparich's field of work. Go ahead.
All right. So I will actually read the first question that came into the chat. It says, do you treat thoracic endometriosis?
Thoracic endometriosis.
Thoracic,
Yes, that's a
yeah.
great question, Chelsea. So we touched upon the typical locations of endometriosis, the pelvis, the ovary, but you're absolutely correct. Endometriosis can grow anywhere. And one of the places that endometriosis can grow into is the lung cavity. So the peritoneal cavity communicates with the chest area through the diaphragm, and the diaphragm is the muscle that helps us breathe. And sometimes endometriosis can be on the diaphragm, or it can even go deep into the lung tissue. Since thoracic area and thoracic organs are typically best managed by a thoracic surgeon, our team approach has been to collaborate with a thoracic surgeon for that portion of the surgery. And we have thoracic surgeons that do robotic surgery, and we have thoracic surgeons that do VATS procedures. But we as a team typically call in the best specialist to address that specific portion of the case. And we're fortunate to work in an environment where we have different specialists available to collaborate with. But the best advocate for endometriosis is always going to be a gynecologist. And so we always try and be present for the cases and be there with the thoracic surgeon to help them recognize what's normal tissue and what to us looks like endometriosis, because it's surprising. They look exactly the same, whether they're in the pelvis, on the ovary, in the lungs, in the liver, in the brain. Endometriosis is always going to look more or less the same. And for our trained eyes, we're able to recognize those lesions and help lead the specialist on, which areas may need to be removed and which look like healthy, normal tissue.
All right, so we have a couple more questions in the chat, and I'll go over to the next question. It's from Zara. It says, any medical therapy for hemato or hydrosalpinx, or is surgical removal the only way to treat it?
I'll take that question, Dr. Stuparich, since it's related to what we discussed on the fallopian tubes. Unfortunately, hydrosalpinx typically means that the tube has lost its function on the inside. So what happens is normally there's cilia, small hair-like particles that push the egg and the sperm together that live inside the fallopian tube. And those cilia also get rid of the debris that can accumulate in the fallopian tube. When there's a hydrosalpinx, which means there's fluid in the tube, or hematosalpinx, which means blood in the tube is dilated, and those cilia particles are no longer doing what they're supposed to do. And so if we drain the fluid, it's just going to reaccumulate. And typically, if it's related to an intrinsic loss of function of the tube, we cannot salvage that tube, and the tube needs to be surgically removed, because like I said, that fluid is not only sitting there doing nothing, it's actually negatively impacting the chances of pregnancy, because it can flow backwards into the endometrial cavity and wash out an embryo that's trying to stick. And so I recommend removal of a hydrosalpinx or hematosalpinx when encountered during surgery. And if there's another functional tube on the other side, then we can still try and get pregnant naturally. But if there isn't, IVF may give us the best chances of conception.
All right, so the next question is from Jusina, and I think she also left another question following her question. So the first one, it says, is it true that endometriosis generates its own estrogens? I think that's what she meant to say. And also the second part, she's asking, hydrosalpinx also needs to be removed in case there is no more pregnancy wish.
Sure, I'll go ahead and take at least the first question. So thanks for your question, Josina. So yeah, endometriosis has a couple mechanisms by which it exerts its terrible effects. So yeah, some implants of endometriosis do in fact create their own estrogen. And so they're almost greedily feeding themselves in a way. And so that's one reason why suppression with hormone therapy like birth control may not exactly work in the way that we think. Another mechanism is that it may actually be resistant to progesterone. Typical birth control usually contains a combination of an estrogen and a progesterone. Estrogen can kind of be thought of as the hormone that thickens or makes the lining of the uterus grow. Progesterone can kind of be thought of the hormone that does somewhat of the opposite and thins it out. And so you can see, with those two processes working together, the fact that it makes its own estrogen, number one, and number two is resistant to progesterone, that it kind of just leaves you with an implant that may just continue to grow on its own. So yes, that is true. And thanks so much for that question. The second part of the question, I'm happy to give my response to, and then I'm happy to kick it over to Dr. Behbehani. A hydrosalpinx, as Dr. Behbehani excellently explained, is basically a swollen tube. There definitely are fertility repercussions, which Dr. Behbehani spoke a little bit about. A hydrosalpinx can also be a source of pain. And so if there is a concern that a hydrosalpinx may be causing a patient pain, then definitely that can be a discussion that would be had between you and the surgeon as to what the benefit of removing that would be. absolutely need to think of whether or not pregnancy is going to be something in the patient's future. So all these considerations are taken into account when we're deciding whether or not to remove a fallopian tube or not.
I agree with Dr. Stuparich, and just to add on that pain, it can also be a nidus for infection, so that hydrosalpinx can turn into a pyosalpinx, and pyo means pus in the fallopian tube. And so if there's no desire for pregnancy, the tube should be removed, especially because it appears abnormal. The other new theory that has recently been introduced into gynecology is the fallopian tube can be the start for ovarian cancer. And so we call those opportunistic salpingectomies if we're going in surgically to do anything, remove an ovarian cyst, remove endometriosis. If the woman has no desire for future fertility and she is looking for contraception, then removing the entire fallopian tube can actually reduce the chances of developing ovarian cancer in the future. So win-win situation if there's no desire for fertility. Next question.
Yeah, so next question is from Anais. And then please let me know if you don't want me to read out your question in the chat, but if it's okay for me to read it out. Okay, thank you. All right, so she asked, she's 41 and at age 25, she had a polyp removed from cervix and sent to pathologist, and the endometriosis of the cervix was diagnosed, and then after it was approved. Oh, she was approved for laparoscopy, and who confirmed stage 4 endo. So does that removed polyp confirm for endo qualifies for adenomyosis diagnosed?
That's a good question. I'm sorry to hear that you had to go through that, first of all. When we remove a polyp, typically it's a growth of something. So on the cervix, interestingly, it was growth of endometriosis. And so if it was from the muscle layer of the uterus, then yes, it would confirm adenomyosis. But because it was on the cervical tissue, I'm assuming based on the information that we have here, it sounds more like endometriosis of the cervix, but it could be adenomyosis if it was from the muscle layer of the uterus. It would be hard to say without actually, being the person who biopsied the area. But stage 4 endometriosis means that the disease is advanced and it is causing a lot of scarring and adhesions inside the pelvic cavity, which goes hand in hand with having endometriosis grow as far down as the cervix. And that can mean that there is adenomyosis of the uterus as well if the disease has made it all the way down to the cervix. I'm sorry to hear that you went through that, and I hope you received the appropriate care. Dr. Stuparich, do you have the chat box? Maybe you and I can read the questions and answer.
Sure, I'll read the next question.
Yep, go ahead.
So, and this one I think has a few questions. So this is from Zizara. How is a ruptured ovarian endometrioma diagnosed? During surgery, how is a previous ruptured ovarian endometrioma identified? Can it be identified visually how recent it was? Where do the contents of ruptured endometrioma go? Is it reabsorbed? Are the contents inflammatory, causing extra/unusual pain for the patient? When a patient has chronic pelvic pain, is there any difference regarding the pain felt for a ruptured endometrioma? Thank you. I'll go ahead and start by addressing some of the questions that were raised. So a ruptured endometrioma is basically a clinical situation where the contents, very similar to the picture that Dr. Behbehani showed at the top of her portion of the lecture, basically come outside of the capsule of the ovary. So it's no longer contained inside the ovary. Typically, diagnosis of something like this would be based on speaking to a patient, performing a physical examination on a patient, in combination typically with some imaging showing some sort of fluid that's in the pelvis. Now, typically, for the next portion of the question, how was a previous ruptured ovarian endometrioma identified? So, unfortunately, without being present at the time of the rupture, there's no way to certainly know if it was in fact a ruptured endometrioma or if it was, for instance, infection that was in the pelvis previously. You may see some signs that something happened. There may be scarring in the pelvis. There may be bands of tissue that we don't expect to see there. So sometimes we can see the evidence that it was there before, but it can be difficult to say with any certainty whether or not it was exactly due to that particular cause. Where do the contents go? I would say some of it could potentially be reabsorbed. If it's a large quantity though, it would take quite a long time for that to be reabsorbed. So a lot of times patients may get taken for an urgent or emergent surgery. For instance, if they get, if they present to the emergency room, and we actually have instruments that allow us to suction those contents and remove them from the pelvis and wash the pelvis quite well. The contents are inflammatory. They are basically the products of tissue that acts like the endometrium or the lining of the uterus. And when that tissue gets inside the pelvis where it doesn't belong, it can be quite inflammatory and cause a lot of symptoms for the patient. Regarding the last portion of the question, every patient perceives pain differently. And so it's very difficult to say exactly how somebody should experience something like that. So there may be differences in pain. It may be referred to different areas in the body. When something typically is on the inside of the body like this, it may be more of a visceral type of pain. So it's a little bit less specifically oriented to one part of the body. It may be a more generalized type of pain. But every patient's experience is individualized and may be different.
Thank you, Dr. Stuparich. I agree. Just for the sake of time, I would love to try and get everybody's questions answered. So I'm just going to go through a couple more really quick. How many endometriosis patients have endo that grows back after surgery? Great question. People always want to know when they go through surgery, do I need to go through that again? And it varies because a lot of people have different techniques when removing the lesion. Some people, if you don't do a wide excision around the lesion, you may be leaving small parts of the disease that may require surgery, sooner rather than later. And I usually quote 20% over 5 years. So 20% of women may require another surgery over 5 years. The way I do my excisions, and Dr. Stuparich does the same, is we do a complete peritonectomy. Cyan, is there a chance we can pull up Dr. Stuparich's image of endometriosis? I just want to show something. I was actually going to unmute my mic and point it out because she had a great picture of fibrosis around endometriotic lesions. And so just like cancer, where do we stop? Where do the margins end? So what Dr. Stuparich and I do is we remove the entire lining, the covering of the pelvic sidewall, so that we remove not only the endometriosis, but all the tissue around it, so that we don't miss any microscopic disease that may grow into macroscopic disease later. Keep going, Cyan. It was the picture.
Probably picture 17 or 18.
It was the surgery picture, yeah. So after laparoscopy. Keep going. Next one. Yep, keep going. Did she skip it? Keep going.
Yeah,
she skipped it.
I think we went too far.
Anyway, that's okay. So it was a picture just of fibrosis that she pointed out, and the one before that. Yeah, this one. And so here you see the one after that, Cyan. You see a lot of white around the blue. Yep, right there. And so where do you stop? Where does that lesion end? It's really hard to tell. And that's why Dr. Stuparich and I do a complete peritonectomy where we remove the entire covering. Everything in this picture would be removed and stripped. And this way, if there's any early disease that we cannot see with our eyes, that the pathologist can see with the microscope, it's all removed. And this theoretically should reduce the risk of the endometriosis growing back and requiring another surgery. And I'm going to just hop onto the question that I saw about postoperative suppression. If you remove the entire covering of the pelvis and you remove all the peritoneum where endometriosis typically grows, you've kind of reset the clock. We're now back to baseline. There is no disease there that's small that will grow into bigger disease. But can disease grow from just ovulation and having periods? We know that it can, unfortunately. Having hormonal stimulation and ovulation every month can sometimes in itself be a nidus for the endometriosis to start growing again. And so suppression of ovulation can help reduce the inflammation associated with ovulation, because ovulation is a very traumatic process for the ovary. If you look at all the biochemical markers that go into ovulation, a lot of inflammatory markers get released every month when women are ovulating. And in women who have pelvic pain, they may be very sensitive to those inflammatory markers. And so I always talk to my patients about individualizing care after surgery. If women have a desire for pregnancy, hormone suppression is not an option because it's not going to change anything. It's only going to delay our goals of getting pregnant. But in women who have a lot of pain with ovulation and they continue to feel that tension in the pelvis when they're ovulating, going on birth control pills is not a bad idea because it suppresses ovulation. And in women who are not trying to get pregnant, it's an added benefit of contraception. Sometimes we put in an IUD. So in women who have adenomyosis, heavy periods, cramping from a uterine source, a Mirena IUD releases local progesterone that acts on the uterus itself and can help reduce the amount of bleeding and cramping that's coming from a uterine source. And so it's individualized care. Do we put women on Lupron after surgery? Absolutely not, because if you've removed all the endometriosis that's there, you don't need the Lupron. You don't need to suppress anything. And I hear that often in women who have advanced stage endometriosis surgery. People remove some of the lesions, pick and choose what is easy to remove and then put patients on Lupron after. If you're on Lupron after surgery, it means that the disease was not completely removed and the physician is hoping the Lupron can manage whatever is left over. And so we don't typically do that here.
I'll go ahead and take, I think, the next 3 questions, and that may be all that we have. That may be all that we have time for. They were somewhat related, so I'll go ahead and address them. So there was a question about, is it safe to take progesterone before surgery to manage symptoms? And then there was a question about using GnRH agonist antagonists as far as pre-treatment. And then there was another question about scarring in the fallopian tube. So I'm happy to address those as we finish out, just in the interest of everybody's time. So I think the decision whether or not to use something as a pre-treatment, as it was referred to, I think it depends on having an in-depth discussion with your doctor about how you're feeling. Some patients are in such debilitating pain that it's reasonable to consider using something palliative before surgery. And by palliative, I mean treating symptoms. As we know, it doesn't necessarily treat disease. There's really nothing that we can say for sure treats disease from a medication perspective. It's not something that I typically do in my practice, but I certainly am more than happy to have a discussion with the patient about what the risks and benefits of something like that might be. As far as it being safe, in most cases, I would say it's reasonably safe. And again, it really just depends upon the potential benefit that we might get from that. But is it something that I commonly do in my practice? Not commonly. What causes scarring in the fallopian tube since endometriosis is found outside of the uterus? Well, so scarring of the fallopian tube could be due to an implant or implants of endometriosis that are implanting on the fallopian tubes. It may also be a product of the inflammation that's occurring because of endometriosis that's nearby the fallopian tube. Or it could be a process that's not at all related to endometriosis. It could be a process like an infectious process. And so there definitely are many conditions that may cause the fallopian tube to have scar tissue and adhesions. So.
Thank you, Dr. Stuparich. I answered the last question in the chat box. I think we're good for now. Thank you everyone for your time and for attending. We will broadcast this talk on social media, so it should be available on Facebook, on UCR Health's website if you're interested in going over the content again. And we're always here to help you. So let us know if you need us for anything else.
Yeah, thanks so much for your time. And thanks for taking the time out of your day to spend some time with us to learn about endometriosis.